welcome to the Deep Dive. Today, we're tackling a really critical topic in pharmacology, anti-seizure agents. We've got Chapter 23 from Focus on Nursing Pharmacology open, and we're aiming to give you that clinical shortcut you need.
We are, and our mission today is, I think, really important. We're going to distill the core concepts of treating epilepsy.
Which is the world's most prevalent neurological disorder.
Exactly. But we're also focusing on that razor's edge of the therapy. It's this constant balance between controlling these life-threatening seizures and, the potential for really severe toxicity.
So we need to know what they do, how they work, and what to watch for.
That's it. What are the dangerous side effects we absolutely cannot miss?
That sets the stage perfectly. So let's start with the absolute basics. Epilepsy is characterized by the seizure,
Right.
which is basically a sudden, massive discharge of electrical energy from nerve cells in the brain.
Yep. But it's so important to remember that not all epilepsy involves those, dramatic full-body convulsions that everyone pictures.
Good point.
A seizure is that electrical burst, and we tend to prefer the term antiepileptic for the drugs because anticonvulsant can be a bit too narrow.
And what about the big emergency, the one everyone fears?
That's status epilepticus. That's where seizures just keep happening, one after another, with no recovery time in between. It's a true medical emergency that needs immediate intervention.
Okay, so the text makes a big deal about moving beyond old terminology. No more grand mal or petit mal.
Yeah, that's long gone. We now classify seizures into two main umbrellas.
So help us kind of visualize that system.
Okay, so first we look at generalized seizures. These are the ones that might start in one little area, but they spread. Well, they spread rapidly through both hemispheres of the brain.
And because that electrical storm is so widespread, the patient usually loses consciousness.
That's right.
And within that category, you have the most aggressive one, the tonic-clonic seizure.
Right, that's the aggressive spasms, the unconsciousness, and it's always followed by this period of just profound exhaustion. But then you have something totally different, like an absence seizure.
And the difference is pretty striking, isn't it?
It's night and day. An absence seizure is short, maybe 3 to 5 seconds. It can just be a temporary loss of consciousness, like a staring spell, often seen in kids.
They can even be missed.
Very easily. And we should also mention febrile seizures. They're distinct because they're triggered directly by a high fever, and they're usually self-limited, mostly in children.
Okay, so let's pivot to the other main category, partial or focal seizures.
So these are different. They're confined to just one specific area of the brain.
So the symptoms you see depend completely on where that electrical discharge is happening.
Exactly. A simple partial seizure could be just a twitch in a finger or a weird sensory change. Consciousness isn't affected.
But the complex partial seizures, that's a whole different ballgame.
It is. We're talking about a whole series of events. It could be emotional changes, hallucinations, repetitive chewing, even things like losing social inhibitions. It's a huge spectrum.
And I'm guessing the reason we're spending so much time on this classification
is because it's the single most crucial step in treatment. These seizures are caused by abnormally sensitive neurons, right?
Right.
So if you misdiagnose the type of seizure, you will absolutely choose the wrong medication. And the treatment will fail, period.
That need for accuracy really underscores the whole challenge. Okay, let's move into the patient experience, because the diagnosis itself carries so much stigma.
Oh, a ton of historical baggage. It was once linked to, evil spirits or mental illness.
So patient and family education is the top priority.
It has to be. You have to educate the entire support system. And from a safety standpoint, every single patient must wear or carry medical identification.
Yeah.
It is non-negotiable.
And the book uses the scenario of JM, a young adult, to highlight the emotional impact.
Yeah.
Getting that new diagnosis reported to the state, which is mandatory in most places, but also means losing your driving privileges.
Which is just a massive blow to your independence. It's a profound psychological issue that we as nurses have to address right along with the pharmacology.
And these challenges exist across the whole lifespan.
They do. In kids, for instance, their metabolism is often faster, so they might need larger doses per kilogram, and you have to watch them so closely for the sedating effects.
What about women of childbearing age? The chapter has some very strong warnings.
This is a huge area of concern. Most antiepileptics are associated with fetal abnormalities, so women must be on contraceptives.
But what if they do become pregnant? You can't just stop the drug.
Exactly. Stopping the drug is extremely risky. You could precipitate status epilepticus, which leads to hypoxia, and that might actually be a greater risk to the fetus than the drug itself. It's a really careful conversation.
We also need to be aware of cultural variations in how people metabolize these drugs.
Absolutely. The text specifically points out that Arab Americans and Asian Americans can metabolize these agents differently.
Due to liver enzyme variations.
Right. So a standard dose could be toxic for them. You have to start with lower doses and constantly adjust based on their response.
All these alerts just highlight the challenge here.
Yeah.
So how are these powerful drugs actually working? How do they stabilize an overexcited brain?
Well, the general mechanism is kind of twofold. We're either stabilizing those hyperexcitable nerve membranes, usually by blocking ionic channels,
Okay.
or we're enhancing the effect of GABA. And GABA is the brain's main inhibitory neurotransmitter. It's like the brake pedal.
And because you're affecting the whole central nervous system, the trade-off is often sedation.
Often sedation and CNS depression, yes.
So let's get into the drugs. Let's start with the classic, Hydantoins, and specifically phenytoin.
Right. Phenytoin is often favored because it's a bit less sedating than some of the others.
How does it work?
It directly influences those ionic channels to stabilize the nerve membrane, but while it's less sedating, its danger zone is really in cellular toxicity.
Okay, so what are we looking at?
We're talking severe liver toxicity, bone marrow suppression, and some critical skin reactions like Stevens-Johnson syndrome. And of course, the one everyone knows, gingival hyperplasia.
The overgrowth of gum tissue.
Exactly. It requires really diligent oral hygiene.
And with phenytoin, monitoring the concentration is everything, isn't it?
It is vital. You have to know that with Dilantin, we have a very, very narrow therapeutic window. Too low, the patient seizes. Too high, they're toxic. And the book's alert is crystal clear. A rash with itching could be life-threatening. You report it immediately.
A medical emergency.
Yes.
Okay, let's move to the big CNS depressants, barbiturates and benzodiazepines.
So barbiturates, like phenobarbital, are just very strong general CNS depressants. They inhibit the reticular activating system, which is basically the brain's on switch.
So profound sedation.
Profound sedation. They also have a really long duration of action and a significant risk of physical dependence and withdrawal.
And what about the benzodiazepines, like diazepam?
They work a little differently. They potentiate the effects of GABA, so they're basically slamming on that inhibitory brake. They're pretty well tolerated, often used as adjuncts.
But there's a crucial warning for all three of these classes, Hydantoins, barbiturates, and benzos.
The big one. The risk of CNS depression is severely amplified when you combine them with alcohol.
Is that really a hard stop on alcohol? Or are some drugs more forgiving?
It's a hard stop. The risk is exponential. The clinical guidance is absolutely clear. Avoid alcohol entirely.
Okay. Let's shift gears to drugs that are really just for absence seizures. That brings us to the succinimides, like ethosuximide.
Right. Ethosuximide is the drug of choice for absence seizures. It suppresses that abnormal electrical activity. But, like many others, it has that key adverse effect of bone marrow suppression.
Specifically pancytopenia.
Yes, a severe reduction in all blood cell lines. So you have to be monitoring the CBC, the complete blood count, mandatory.
We also see valproic acid used here, and that one comes with some massive warnings.
It does. Valproic acid carries a really high risk of hepatotoxicity, liver damage, and a critical warning about birth defects. It's actually pregnancy category X when used for things like migraine prevention.
So liver function tests are non-negotiable.
Non-negotiable.
Okay, now we're getting into the territory of partial seizure agents. And the black box warnings here, they're genuinely alarming.
This is a critical distinction. Every single drug used to treat partial seizures carries a black box warning for the potential of increased suicidality.
Every single one.
Every one. Which means, as a nurse, you have to monitor the patient's mental and emotional state just as closely as you're watching their blood counts.
The prototype here is carbamazepine. What's unique about that one?
So it's chemically related to tricyclic antidepressants, and it blocks sodium channels. But what's really fascinating, and a key point for dosing, is something called autoinduction.
Autoinduction.
The drug actually induces the liver enzymes to increase its own metabolism over time.
So the longer they take it, the faster their body gets rid of it.
Exactly. So you have to constantly watch the serum levels because the patient is clearing the drug faster and faster.
Let's talk about those really chilling warnings on some of the newer agents.
Yeah, some are pretty intense.
Ugh.
Take perampanel. It has a black box warning for serious psychiatric reactions, including aggression and even homicidal ideation.
Homicidal ideation, right?
It blocks glutamate, which is the brain's main accelerator. So when you dramatically inhibit that excitatory neurotransmitter, you can get some extreme behavioral changes.
And lamotrigine.
Lamotrigine is notorious for being associated with serious, sometimes life-threatening rashes. If a patient on lamotrigine develops any kind of rash, you stop the drug immediately.
We should also mention two others, pregabalin and vigabatrin.
Right. Pregabalin, or Lyrica, is a controlled substance because it can cause euphoria.
Right.
And vigabatrin, well, vigabatrin carries the risk of permanent loss of vision.
Permanent.
So for that drug, rigorous monitoring of their visual field before and during treatment is an absolute requirement. These are not minor side effects.
No, they're life-altering. Which leads us perfectly into nursing implementation. With all these risks, liver, bone marrow, mood, vision, what are the top directives for nurses?
First and foremost, the #1 safety rule. Never withdraw the drug quickly.
Never.
Rapid cessation can trigger status epilepticus. All of these drugs have to be tapered off slowly.
And the monitoring checklist, what's on it?
Monitor the CBC periodically for bone marrow suppression. Liver and renal function tests are mandatory for dose adjustments, especially with valproic acid. And of course, keep an eye on those serum drug levels.
Right.
And we also advise giving most of these with food to help with the GI irritation.
Let's just reinforce that pregnancy risk one last time.
Yes. Because so many of these agents can make hormonal contraceptives less effective, women of childbearing age should be advised to use barrier contraceptives.
And watch out for herbal interaction.
Definitely. Things like evening primrose can increase seizure risk, and ginkgo can interact with some of the barbiturates.
Okay, let's bring it back to JM, the 18-year-old on medication for tonic-clonic seizures. What's the focus of nursing care for him?
For JM, it's all about medication adherence, #1. Then, frequent oral hygiene because of that gingival hyperplasia risk with phenytoin. And then, a lot of psychological support.
Right, coping with the diagnosis, the driving restrictions, the fear.
It's a massive emotional load. The nursing role is often about managing the life around the medication.
So if we pull all this together, what are the 2 or 3 things a clinician absolutely needs to walk away knowing from this chapter?
I'd say this. Know the drug's primary mission. Is it stabilizing membranes or is it enhancing GABA? Know that the general side effects are CNS depressing, drowsiness, fatigue.
But the core priority.
The core clinical priority is managing the severe specific toxicities, the liver, the bone marrow, the skin, and the mental health risks. You are constantly working to keep the patient safe from the drug while the drug is keeping them safe from the seizure.
Here's our final thought for you. These medications are foundational for controlling seizures. But long-term compliance is just extraordinarily difficult. You're dealing with those persistent CNS side effects, the organ toxicities, and that loss of independence, and that continuous need for education, support, and safety nets, like a medical alert tag, that really defines the depth of care that's required here.
It's pharmacology that demands profound patient advocacy.
Thank you for joining us for this deep dive. We'll catch you next time.